Good afternoon. My name's Henrik Olson. I'm a PGY2 critical care pharmacy resident, currently completing my residency at University of Minnesota Medical Center. So this will be the second time that I am submitting a presentation to the Minnesota Society of Healthcare Pharmacists Outstanding Research and Poster Presentation Contest. Today I'll be discussing my current year-long project, which was looking at the peripheral administration of 3% sodium chloride and syringe-based delivery of 23.4% sodium chloride. So this project really aims to explore the safety, efficacy, and institutional policy changes around these practices, and we'll look at some existing literature, look at the methods that we're using, and discuss the anticipated outcomes of expanding these administration methods throughout our institution. So a little bit about background and implications of hypertonic saline in both of these dosage forms. So hypertonic saline obviously plays a vital role in managing neurological emergencies specifically, and this is where rapid treatment can be life-saving. So 23.4% sodium chloride is traditionally administered via central venous access. Big thing here is that we currently, within Fairview, we use piggyback administration, which takes time to compound as well as get up to the units, as well as hang, program pumps, and get administered to patients. And this can all be time consuming, which is why we are looking at the feasibility of switching to syringe-based administration for this particular medication. Additionally, 3% hypertonic saline has been shown with promise in peripheral administration under controlled conditions, but our current institutional guidelines restrict its prolonged usage. And through this project, we really aim to highlight those potential policy changes through our extravasation policy, through our medication safety committee, and finding those key opinion holders within our floors to help essentially vet this process so that it can be implemented operationally throughout our institution. So it's important to clarify the significance of this research. So this isn't necessarily a traditional research year-long project in the sense of, raw data collection, etc. However, this is more of an administrative quality improvement initiative aimed at optimizing our current hospital protocols. So there was literature, which we'll talk about in our methods section, which was reviewed, as well as internal literature, which was composed and conducted to help us come to a research decision for these recommendations. But our goal here is really to obtain approval from key opinion holders, push these changes forward through our medication safety committee. And the hope here is to improve treatment efficiency, patient safety, particularly in these neuro cases. And this would allow us to be more flexible and effective in our use of hypertonic saline in these critical care scenarios. So this is part of our review of existing literature listed on this slide, but current literature does provide some valuable insight into the potential safety and efficacy of peripheral administration of hypertonic saline, as well as syringe-based delivery of hypertonic saline. So studies within this slide do show that 3% can be safely administered peripherally when appropriate monitoring is in place. We've also gotten word by working with Dr. Bentho and one of his clinical pharmacists who he used to work in the neuro ICU at Johns Hopkins. So getting to look at some of their protocols, which allow for extended use of 3% sodium chloride administration in the ICU and intermediate care patients. And then obviously we have this retrospective data to suggest that the incidence of extravasation is low when using a large bore intravenous access site. Syringe-based administration of this 23.4% has been reported as well tolerated. There hasn't been necessarily comprehensive safety comparisons. Those are limited, but institutional review at mHealth Fairview does show that this is something that can be used safely and efficaciously. So that's a little bit of background of some of the reviewed external and internal literature which we have been compiling. Um, so as far as our research specific aims, this is a quality improvement administration project. We'll be obtaining some key opinion holder approval for policy updates. All these changes are going to have to go through the Medication Safety Committee for final approval. And this consists of a large committee composed of clinical pharmacists, nursing leaders of various floors, including ICU, emergency department, neurocritical ICU, um, intermediate care, and general med-surg units. And then, having the ability to have improved protocols could enhance our patient safety and obviously allow our frontline care clinicians, such as our nurses, to be able to administer this when ordered. Additionally, um, once these implementations are pushed forward, I'll also be working on with our Epic Willow team to be able to get these from our virtual environment into Epic itself to make sure that we have the order sets in place for ease of ordering by our clinicians. So for this project, we conducted a retrospective multi-center review of patient data within mHealth Fairview. So that was for both 23.4% and 3%. And essentially, we didn't look at pediatric patients for these populations. So a lot of the pediatric literature that we had to rely on was external. But this looked at key clinical markers in ICP, MAP, serum sodium, osmolality, and this was previously done by a previous resident. But essentially, we looked at safety data, and the adverse events were assessed, which supported our findings being relatively low, only 2 extravasation events overall with the 3% group, and an additional very low number with the 23.4% group. So this helped us identify discrepancies, opportunities for policy refinement from an internal perspective. So our anticipated outcomes, as we're sort of, gathering our SBAR data, continuing to get key opinion holder recommendations, is once these are implemented through our protocols, we'll look at our safety with 3% and 23.4% administration. We're anticipating improved response times in neuroemergencies, and then reduce reliance on our central line placement overall, specifically for that 3%. These are some of the references that I used, and thank you so much for listening to my presentation.